Hello, I'm Bobby Jean Schweitzer, and I'm presenting Anesthesia for Ambulatory Surgery Part 1. The lecture modules will consist of morbidity and mortality of ambulatory surgery, conditions associated with higher risks for ambulatory surgery, and mitigating risks. So we'll start with morbidity and mortality of ambulatory surgery. We're going to start with a question. A surgeon wants to schedule an American Society of Anesthesiologists, or an ASA, for a patient for an open reduction in internal fixation of a wrist fracture in your ambulatory surgery center. He's requesting a nerve block because the patient has a history of postoperative nausea and vomiting. Which of the following statements is accurate? A, with an aging population, fewer patients are being done in the outpatient setting. B, ASA Class 3 and 4 patients should not be done in ambulatory surgery centers. Post-op nausea and vomiting is the highest single reason for unexpected postoperative hospital admission due to anesthesia. Or D, regional anesthesia should not be performed in an ambulatory surgery center. And the answer is C. Postoperative nausea and vomiting is the highest single reason for unexpected postoperative hospital admission due to anesthesia. So answer C is correct because post-op nausea and vomiting remains difficult to prevent. Answer A is incorrect because patients are aging and demanding, requiring, and expecting surgeries in outpatient surgery centers. Answer B is incorrect because it is now customary to accept ASA 3 and even 4 patients for low-risk ambulatory surgeries. And answer D is incorrect because regional anesthesia has lots of advantages even in ambulatory settings. So this slide represents the mortality based on the ASA physical status scoring system, which you are all familiar with. ASA 1 patients typically have a 0.03% risk of mortality. That rises very slightly in ASA 2 patients to a level of 0.8. ASA 3 patients is where you see the first big significant increase. And even for low-risk patients, it remains quite low. For low-risk surgeries, it remains quite low. For higher-risk surgeries, that rise is even higher. At ASA 4 levels for low-risk surgery, 3.31% of patients will suffer mortality. And ASA 5 patients have over a 7% risk of mortality. Morbidity is slightly higher, and morbidity also tracks along with ASA physical status scoring. This shows the percentage of mortality for intermediate risk procedures compared to the previous slide, which showed the mortality for low risk procedures. So you can see the rise continues, and the big jump up occurs between, the rise starts to occur between patients who are at ASA 2 to ASA 3, and the rise is steeper from ASA 3 patients to ASA 4 patients. So looking at the risk of unplanned admissions, which is typically more common and more pertinent to ambulatory surgery centers, since we do know that the risk of mortality is quite low. The risk of unplanned admissions are associated to the age of the patient, underlying medical conditions, and the type of procedures performed. There's an approximately 3% risk of unplanned admissions, and the most common reasons are surgical, 40%. Anesthesia accounts for about half of the surgical risk at 20%. Medical reasons account for equal numbers as anesthesia, and social reasons such as not having an escort home account for about 12%, and miscellaneous reasons account for the remainder. So there's an increased risk of unanticipated admissions with patients who are older than age 80. Prior hospitalizations within the previous 6 months before surgery increases one's risk. Moderately invasive procedures are more likely to be associated with unplanned admissions. And the length of stay, length of surgery that is greater than 1 hour increases one's risk. ASA physical status scoring also predicts risk, with the risk rising in those who are ASA 3 and higher. And patients who are overweight or obese have a higher risk as well. So the causes are related to the setting where the surgery is done. There's a higher risk in surgeries performed in an office-based or outpatient hospital setting versus a freestanding ambulatory surgery center. As mentioned earlier, the longer the procedure is, the higher the risk, and the postoperative bleeding can lead to anticipated admissions, difficult to control pain, and difficult to control nausea and vomiting, which again is the most frequent cause of anesthesia-related admissions after ambulatory surgery. So let's look at some conditions that are associated with the higher risk for ambulatory surgery. Another question. Here, the manager of the ASC wants to establish guidelines for appropriate patient criteria, and they reach out to you. Which patient is a poor candidate for surgery in a freestanding ambulatory center? A 23-year-old with a history of malignant hyperthermia who is scheduled for sinus surgery. B, a 47-year-old patient with a history of obstructive sleep apnea who uses continuous positive airway pressure without other medical problems, who is scheduled for an inguinal hernia repair. C, a 3-month-old ex-preemie who was born at 32 weeks, who is scheduled for a circumcision. And D, an obese 75-year-old with diabetes, stable coronary artery disease, who is scheduled for a knee arthroscopy. And the answer is C, the 3-month-old ex-preemie born at 32 weeks for a circumcision. This answer is correct because this patient is at risk of postoperative apnea and is best observed overnight after a general anesthetic. Answer A is incorrect because dantrolene is available and the usual cautions can be taken to safely provide care for patients with malignant hyperthermia in an ambulatory surgery center. Answer B is incorrect because the Society for Ambulatory Anesthesia guidelines indicate it is safe to provide care for patients in ambulatory settings with obstructive sleep apnea if they're using a CPAP and if they have well-controlled or no comorbidities. Answer D is incorrect because this is a typical patient who routinely has ambulatory surgery. So what are the factors that impact the risk of ambulatory surgery? Well, you can divide those into patient factors and surgery factors. Patient factors are comorbidities and the degree of the stability or control of those comorbidities. The age of the patient, the BMI, social and cultural conditions, such as their expectations around ambulatory surgery and their support, and the availability of an escort. The surgery risks are related to the site and the duration of the procedure itself, the degree of invasiveness, the risk of the perioperative complications, the risk of blood loss, and any anticipated postoperative pain. The factors impacting risk are also related to anesthesia and the facility where the procedure is performed. The need for general anesthesia increases the risk, and the need for tracheal intubation and mechanical ventilation increases risk. Freestanding surgery centers typically have a lower risk compared to hospital-affiliated or office-based settings. And the distance and the time to emergency surgeries should be taken into consideration so that if there is a complication, that outcome can be improved and risk mitigated. So what age is too young for a patient to be a candidate for an ambulatory procedure? Well, the risk of apnea is inversely related to post-conceptual age. There's a less than 5% risk of apnea in infants who are at 60 weeks post-conceptual age. A term infant who was born at greater than 36 weeks should be at least greater than or equal to 48 weeks post-conceptual age, which is typically the age of a 2 or 3 month old. Preemies, which are defined as babies who are born between 32 and 36 weeks, should be at least 52 weeks post-conceptional age, or typically about 4 to 5 months old, to lower the risk. Micropreemies are defined as those individuals born at less than 32 weeks, and they should be at least 60 weeks post-conceptional age, or at least 7 months old. Anemia does increase the risk. Studies have shown that hematocrits of less than 30% are associated with increased risk. And what about individuals who are too old for ambulatory surgery centers? Well, in a study by Morbidity, there was a 0.8% admission rate for patients less than 60 years of age, and that increased to 1.1% for those greater than 60 years. There was also an increased risk of inpatient hospital admission and death within 7 days that was associated with age greater than 85 years. Prior hospitalization within 6 months, as we mentioned earlier, a procedure performed in an office or outpatient hospital setting versus a freestanding setting, and those associated with moderately invasive procedures. So what about some comorbidities that predict major complications? This is a list that came from the Surgical NSQIP database, the American College of Surgeons, and they identified COPD, a history of cerebral vascular disease, which was defined as either a stroke or a transient ischemic attack. Patients with BMIs of greater than 30, though the highest risk was those associated with BMIs of 50 and greater. Prior percutaneous coronary interventions, such as angioplasty with or without stenting, prior cardiac surgery, a prolonged operative time, and the presence of hypertension. These conditions were moderate predictors of major complications. Para or quadriplegia, cancer, renal failure or the need for dialysis, steroid use, age greater than 80 years, or a history of heart failure. And these were predictors of major complications that were less strongly predictive. Diabetes, age of 71 to 80 years of age, and possibly sleep apnea. So what are the absolute contraindications to ambulatory surgery? Typically, patients who are considered ASA 3 or 4 patients who have unstable medical conditions, such as severe pulmonary hypertension or diabetic ketoacidosis, are not candidates for ambulatory surgery. Patients with extreme obesity, typically a BMI greater than 51, who have associated comorbidities, particularly if those comorbidities are poorly or inadequately controlled. In patients with sleep apnea who have significant or poorly controlled comorbid conditions. Those with suspected or untreated sleep apnea, if opioids are to be given. Those with acute substance abuse who may be at risk for withdrawal. And possibly patients who have left ventricular assist devices, though there are some centers accepting these kinds of patients, particularly for very minimally invasive procedures such as cataract surgery. So how does one mitigate the risk? Let's start with a question. A general surgeon calls you to ask if he can book an inguinal hernia repair on a 55-year-old patient with a history of aortic stenosis, heart failure, an implantable cardioverter defibrillator placed for a history of VTAC arrest, who had a myocardial infarction 3 months ago. Which condition is an absolute contraindication for ambulatory surgery in this patient? A, an MI 45 days prior. B, implantable cardioverter defibrillator presence. C, a history of a New York Heart Association Class 2 heart failure. Or D, aortic stenosis with a mean gradient of 33 millimeters of mercury. And the answer is a myocardial infarction 45 days ago is considered an absolute contraindication to any types of surgeries, even non-ambulatory procedures. This is according to the 2014 ACC/AHA guidelines, which recommend postponing elective surgeries for 60 days or more after a myocardial infarction. Answer B is incorrect because patients with ICDs can be cared for in the ambulatory surgery center with appropriate planning. Answer C is incorrect because Class 2 heart failure is indicative of mild to moderate disease and is not an absolute contraindication for ambulatory surgery. Answer D is incorrect because moderate aortic stenosis is not a contraindication for ambulatory surgery either. So what are some of the advantages of anesthesiology-directed perioperative medicine clinics? They have been shown to enhance patient safety, improve patient satisfaction, minimize preoperative consultations, reduce surgical case cancellations and postponements, and even decrease mortality. Thank you very much for your attention.